Hello everybody. Welcome to number 1 Doctor channel. Today we will talk about carcinoma of the rectum. Welcome doctor.
Welcome to you and your channel subscribers.
Doctor, what about the pathology of carcinoma of the rectum?
The sexes are equally affected. It occurs in any age group from the 20s onwards, but is particularly common in the age range 50 to 70 years. Carcinoma of the rectum accounts for approximately 1/3 of all tumors of the large intestine. Predisposing factors, as with carcinoma of the colon, are pre-existing adenomas, familial adenomatous polyposis and ulcerative colitis. Macroscopic appearance. The tumors may be classified as follows: papilliferous, ulcerating, most common, stenosing, usually at rectosigmoid, mucinous, colloid. Microscopic appearance. Rectal carcinomas are adenocarcinoma. About 9% are associated with profuse mucus secretion, colloid tumors, and 1% are highly anaplastic adenocarcinoma. At the anal verge, squamous carcinoma may occur, but a malignant tumor protruding through the anal canal is more likely to be an adenocarcinoma of the rectum invading the anal skin.
Doctor, what about spread of rectal carcinoma?
1. Local. Circumferentially around the lumen of the bowel. B. Invasion through the muscular coat. C. Penetration into adjacent organs, for example prostate, bladder, vagina, uterus, sacrum, sacral plexus, ureters and lateral pelvic wall. 2. Lymphatic, to regional lymph nodes along the inferior mesenteric vessels. At a late stage, there is invasion of the iliac lymph nodes into the groin lymph nodes, by retrograde spread and involvement of the supraclavicular nodes via the thoracic duct. 3. Blood. Via the superior rectal venous plexus, that's via the portal vein to the liver and then lungs. 4. Transcoelomic. Seeding of the peritoneal cavity.
Doctor, what about the staging of rectal carcinoma?
The extent of spread of rectal tumors is traditionally classified by Duke's method. A. The tumor is confined to the mucosa and submucosa. B. There's invasion of the muscle wall. C. The regional lymph nodes are involved. D. Distant spread has occurred, for example to the liver or invasion into the bladder. More recently, colonic and rectal cancers have been staged using the TNM system. TIS. The tumor involves the mucosa only. T1. The tumor is confined to submucosa. T2. The tumor invades the muscle wall. T3. The tumor invades through the muscle wall into the serosa, or pericolic or perirectal tissue. T4. The tumor invades other organs, or has perforated into the peritoneal cavity. N0. No regional lymph nodes. N1. Tumor involves 1 to 3 lymph nodes in pericolic or perirectal tissue. N2. Tumor involves more than 3 lymph nodes in pericolic or perirectal tissue or any nodes more than 3 centimeters away from the primary tumor. M0. No distant metastasis. M1. Distant metastasis.
Doctor, what about the prognosis of rectal carcinoma?
Depends largely on the stage of progression of the tumor and its histological degree of differentiation. The more advanced its spread and the more anaplastic its cells, the worse the prognosis.
Doctor, what about the clinical picture of rectal carcinoma?
The patient may present with local disturbances owing to the presence of the tumor in the rectum, manifestations of secondary deposits, the general effects of malignant disease. Effects of secondary deposits and malignant disease are similar to those of carcinoma of the colon, with the addition that, rarely, carcinoma of the rectum may spread to the groin nodes as a late phenomenon. With carcinoma at the anal verge, this commonly occurs. Local symptoms. Local symptoms include bowel disturbance, constipation and or diarrhea occur in 80% of cases, and bleeding, which is almost invariable and is the presenting complaint in about 60% of patients. There may also be mucus discharge, rectal pain and tenesmus. Examination. Abdominal palpation is negative in early cases, but careful attention must be paid to the detection of hepatomegaly, osteocytes or abdominal distension. Other general features that may be detected in late cases are enlarged supraclavicular nodes, nodes in the groin or jaundice. Rectal examination reveals the tumor in 90% of cases.
Doctor, any special investigations for rectal carcinoma?
Sigmoidoscopy enables the great majority of tumors to be inspected and a biopsy to be taken. Colonoscopy is indicated to rule out synchronous tumors if a second tumor is suspected. 5% of tumors in the large bowel are multiple, or if there is ulcerative colitis or familial polyposis. Barium enema is indicated when colonoscopy is not readily available. Computed tomography of the chest, abdomen and pelvis is performed to detect metastatic spread. Magnetic resonance imaging of the pelvis is useful for preoperative staging of the tumor and for planning preoperative radio and chemotherapy.
Doctor, what about differential diagnosis of a rectal tumor?
Differential diagnosis of a palpable tumor in the rectum must be made from the following. Benign tumors. Carcinoma of the sigmoid colon prolapsing into the pouch of Douglas and felt through the mucosal wall. Secondary deposits in the pelvis. Ovarian or uterine tumors. Extension from carcinoma of the prostate or cervix. Diverticular disease. Endometriosis. Lymphogranulominguinal. Amoebic granuloma. The rare malignant tumors of the rectum. Feces. These give a classic physical sign of indentation. The beginner may mistake the normal cervix for a palpable tumor, and should not be caught out by the presence of a ring pessary or tampon in the vagina, which are readily felt per rectum.
Doctor, what about the treatment of rectal carcinoma?
Curative treatment includes surgery. Surgery depends upon the distance of the tumor from the anal verge. Upper third tumors can be resected with restorative anastomosis between the sigmoid colon and the lower rectum, anterior resection. Lower third tumors, less than 5 centimeters from the anal verge, are usually treated by abdominoperineal excision of the rectum, with a terminal colostomy. Adjunctive radiotherapy may reduce the incidence of local recurrence after abdominoperineal resection. Mid-third rectal tumors can usually be treated by anterior resection, provided satisfactory distal clearance can be obtained. The operation is easier in women, in whom the wider pelvis facilitates dissection. Adjuvant therapy. Preoperative radiotherapy reduces the risk of local recurrence, and is often combined with chemotherapy, 5-fluorouracil or capecitabine. Radiotherapy may either be external beam or brachytherapy, internal radiotherapy, delivered from a source placed in the rectum for 10 to 15 minutes. Palliative procedures. Even if secondaries are present, palliation is best achieved when possible by excision of the primary tumor. A colostomy may be necessary for intestinal obstruction, but this does not relieve the bleeding, mucus discharge and sacral pain. In completely inoperable cases, radiotherapy, diathermy or laser of the tumor may give temporary relief, as may cytotoxic drugs.
Thanks, doctor, for excellent informations.
Thanks for you and for your channel subscribers.
Thanks for watching. Hope to see you again in more next videos. But please don't forget to like and share our videos and subscribe to our accounts in social media and links below each video. With my best wishes. Dr. 8 Fahmed.